Welcome everyone to our Lunch and Learn webinar for May 17th. My name is Allison Napier, and just want to thank you for joining. Our presenter today is Dr. Portia Flowers. She's a Post-Doctoral Fellow at Thurston Arthritis Research Center. And Dr. Flowers is a skilled researcher with over 10 years of experience developing research questions, utilizing various motions and analysis techniques, and analyzing biomechanical, clinical, and functional data. Her research at University of Delaware focused on biomechanical and clinical influences on recovery and osteoarthritis progression after total knee arthroplasty. So in this webinar, she'll be discussing her research and racial differences in joint hypermobility injury and osteoarthritis. So welcome, Dr. Flowers.
Okay, thank you so much, Allison, for that introduction. And I'll get right into it. So the CDC defines osteoarthritis, or OA, as a degenerative joint disease of the articular cartilage. It's the most common form of arthritis, and it is a leading cause of disability. The most common location for OA is at the knee. And here we have an illustration of a knee with OA, and you can see the worn away cartilage with exposed bone underneath. You can also see damage to the meniscus as well as bone spurs. So it's not unusual for OA to be accompanied by several other physical developments and injuries. The second most common location for OA is at the hand, and then followed by the hip at third. And this is all for symptomatic OA. Between 2010 and 2012, over 52 million adults in the U.S., so that's about 23% of the population, reported doctor-diagnosed arthritis. And recent projections estimate that by 2040, the prevalence of diagnosed arthritis will escalate to over 78 million, or almost 26% of the population. OA is often accompanied by pain, muscle weakness, and physical impairments such as flexion contractures, and reduced passive joint range of motion, and reduced functional ability. If we could cue up the video here. We'll see that there's a woman with knee OA. She's walking across the floor, and we can assume that she's in pain. You can tell her ability to walk is limited by the shortness of her steps and reliance on a cane for support. So shorter steps are indicative of reductions in joint range of motion, possibly due to joint stiffness or muscle weakness, with certain muscles not being able to support the body beyond a certain range. So all of this adds up, and without intervention, her condition could become worse. So the rising number of adults with OA, along with associated activity limitation, presents a serious public health problem. Although OA is the most common form of arthritis, and an increasing number of people are being diagnosed each year, not everyone has it, and not everyone will develop it in the future. So what puts some people at a higher risk to develop OA than others? And what are some of the risk factors associated with OA? Well, in simplistic terms, risk factors can be divided into two categories: systemic, which speaks to the susceptibility one has to developing OA in a general sense, and local. And that speaks to the susceptibility one has to developing OA in a particular location in the body, and or a severity of OA once it is already developed. And I'll mention a few risk factors here, starting with systemic. So age is considered to be a huge systemic risk factor for OA. Prevalence increases with age, and it is believed that an accumulation of compressive forces on the articular cartilage is the primary culprit. Gender is also considered to be a risk factor, with women being more likely than men to not only have OA, but to have more severe OA. Congenital or developmental abnormalities can also be a factor. So conditions that you're born with or develop could impair normal joint motion and can lead to cartilage damage, thus increasing the risk for OA. Race and ethnicity have also been found to be risk factors, and I'll get into that. So we know that racial differences exist for other diseases already. Cardiovascular disease and diabetes, for instance, those are two examples of diseases with a higher prevalence among African Americans and Latinos compared to non-Hispanic Caucasians. So similarly, racial differences exist within OA as well. So if we look at it from an epidemiological perspective, we know that African Americans have a lower lifetime risk of symptomatic hand OA compared to Caucasians. African Americans also have less frequent radiographic hand OA, but more frequent knee OA compared to Caucasians. African American men have a higher prevalence of radiographic hip OA compared to Caucasian men. African Americans with hip OA have more severe superior joint space narrowing and more osteophytes compared to Caucasians. African American men are more likely to have tibial-femoral OA compared to Caucasians, and African Americans overall have more severe tibial-femoral OA than Caucasians. So those are just some of the ways that Caucasians and African Americans differ from an epidemiological perspective. Moving on, demographically, we know that African Americans tend to be younger and have a higher proportion of females with OA compared to Caucasians. They also have greater BMI when disease severity is equal. And of those with OA, African Americans tend to have a lower socioeconomic status compared to Caucasians. They also report more depressive symptoms and less self-efficacy, which is a measure of how certain one is of their ability to perform a certain task or activity. And African Americans also have worse self-reported functional outcomes. So all of this is to say that in a variety of ways, African Americans with OA have been described as being quite different from Caucasians with OA. And these differences may be apparent in other ways as well. So now we'll move on to local risk factors, which again speaks to the more modifiable ways in which one is at risk for developing OA. So obesity is a risk factor, especially in weight-bearing joints, such as the hip and the knee. The Framingham study and IDEA study both illustrated the relationship between weight loss and improvements in OA risk and physical function. Joint injury is also a big risk factor. Anything that might disturb the structural integrity of the knee, such as of the joint, such as ACL injury or meniscal tears, shifting the contact area on the cartilage surface, for instance, that can put you at risk. Physical activity is also considered a risk factor, which may be surprising to some because generally any amount of physical activity is supposed to be a good thing, but there's limits to the benefits of physical activity. Some studies have shown physical activity to be protective, while others suggest that strenuous activity is a risk factor for knee OA, for example. So it seems that the combination of the quality of activity, so low versus high impact, as well as the quantity of activity, so the amount of time spent exercising per week, for instance, that seems to complicate the relationship between physical activity and OA. And another risk factor for is biomechanics, and that's where we're thinking about not only the static joint alignment or structural alignment, but we're also thinking about the ways in which the joints move and coordinate movement to complete a task. And this is where we'll focus our attention now. So we understand that everything is connected. With joint pain comes limitations in mobility, and that brings about reductions in the amount of physical activity one has, and that can lead to weight gain and obesity, which can lead to increased contact forces and pressure on the joints, resulting in further cartilage deterioration and increased joint pain. And of course, intermingled with that are cardiovascular disease, diabetes, and depression, which are common comorbidities of osteoarthritis. And at the center of this cycle is movement. With increased movement, the potential to improve quality of life, reduce the symptoms of OA, and slow down the progression of OA is improved. Just moving can improve your health status. So we know that the quantity of movement is key, but the quality of movement is important as well. Because if you're moving in a way that encourages and promotes OA progression, then you could be cutting into any improvements you might be making with increased physical activity and reductions in body weight. So let's first talk about normal gait and then abnormal gait, commonly seen in patients with lower limb osteoarthritis. So normal gait is generally defined as a series of alternating movements of the trunk and limbs to advance the body forward. Within a gait cycle, you have two phases. stance phase, where the limb is in contact with the floor for about 60% of the cycle, and swing phase, where the limb is not in contact with the floor for the remaining 40% of the cycle. You can see that our reference limb here is that gray limb. And the stance phase can be broken down even further. At initial contact, the hip is flexed and the knee is extended. At mid-stance, the knee is now extended. As the limb transitions into terminal stance, the hip is now in extension and the knee becomes slightly flexed. And at toe-off or pre-swing, the hip and knee move into flexion to lift the foot off of the floor and into swing phase. So first, just a little background. There's different ways to analyze human movement. You can look at it qualitatively, quantitatively. You can look at muscle activation. You can look at biological processes associated with motion. But motion analysis testing in a Gait lab can be utilized to quantify human movement in a very technical way, placing tracking markers on strategic locations on the body that are recorded by special cameras placed throughout the lab. You can capture a person's movement. Typically, a person will walk across the floor and over embedded force plates, which are like high-tech bathroom scales. And they measure the ground reaction forces associated with the movement. So as the person walks, they apply a force onto the ground, and the plates measure that force. So using this motion analysis technique, A. Stephen and colleagues were able to describe the changes in lower limb biomechanics resulting from knee OA in a seminal study in 2008. The purpose of this study was to determine if lower limb kinematic and kinetic gait variables differ between those with and without knee OA, and if those variables change depending on OA severity. And just to make sure everybody's on the same page, kinematic data is data that describes the motion of an object, so joint angles, joint velocities, those are examples of kinematic variables. Kinetic data is data that describes forces associated with the motion of an object. So ground reaction forces, joint torques or moments, powers, those are examples of kinetic variables. So here they measured 3 groups. Asymptomatic, which is described as individuals with no history of knee pain or surgical intervention in their lower limbs. Moderate knee OA, and these are people who are not yet eligible for total joint replacement surgery, but may have received exploratory arthroscopic surgery. And severe knee OA, and these are people who are recommended for total joint replacement surgery. All participants underwent 3-dimensional motion analysis testing, walking at a self-selected speed that was normal for the individual. And so now I'm just going to talk about the results in the sagittal plane. So that's the plane of motion that involves flexion or bending of the knee and extension or straightening of the knee. And so here we have a graph of knee flexion angle over a complete gait cycle. So from heel strike to heel strike of the same limb, how much does the knee flex and extend? And we have our asymptomatic group represented by the solid line, moderate knee OA by the dashed line, and severe by the dotted line. And so we see that all 3 groups generally move similarly throughout gait cycle as it should, as the foot makes contact with the ground. The limb accepts the weight of the body, and the knee flexes to absorb the shock and then moves into extension around mid-stance to provide a strong base of support as it moves into single limb stance. Then the knee flexes as the limb moves into swing phase and returns to full extension as the foot returns to the ground. But as you can see, there are differences in the range of motion between the 3 groups, and they're most apparent at peak knee flexion, which is the shaded parts that you can see there. During loading response, as the limb starts to take on the weight of the body while absorbing the shock of the force from the floor, OA knees flex less than knees that don't have OA. And knees with severe OA flex less than knees that have moderate OA. So you can see that progressive OA is associated with reduced knee flexion. And then later on during swing phase, the foot lifts off of the ground, the limb advances forward, but those with severe knee OA don't flex their knees as much as those with moderate or no OA. And so you can imagine that could potentially be a problem when we're talking about foot clearance. So the take-home message here is that peak knee flexion decreases with progressive OA during stance phase, and peak knee flexion is lower in severe OA during swing phase. So next we have a graph of knee sagittal plane moments, and joint moments simply give us an idea of the type of demand required for a muscle group to complete a joint motion. So in this graph, we're looking at the muscle demands required to support the knee throughout the gait cycle. As the foot makes contact with the ground, you see a bit of an extensor moment here indicating that the knee is in extension and the ground reaction force is acting in a way that encourages extension, so a counteracting flexion force must be generated to balance that out and stabilize the knee. During a loading response phase, body weight is transferred to the stance limb and the knee extension muscles or quadriceps must counteract the external knee flexion moment generated by the ground reaction forces. Normal gait mechanics require that the quads act like a shock absorber and attenuate the external force. So the force of the ground wants to flex the knee, but the motion must be controlled. So extensor muscles are activated to slow that flexion down. Otherwise, you'd collapse. And going into terminal stance phase, again, the limb is applying force onto the ground as the knee extends, but to control this motion, knee flexor muscles come into play to help stabilize the knee. And then the graph goes a bit weird in swing phase. So just to explain, joint moments are calculated through a combination of joint angle and ground reaction force. So since the foot is no longer on the ground, there's no ground reaction force to calculate that moment. So that's why it goes a bit haywire. Joint moments are usually reported just for the stance phase. So I'm not sure why they decided to extend that. But anyway, again, there are differences in the flexion and extension moments between the groups, occurring mainly in early and late stance. At initial contact, you can see that progressively worse OA corresponds to reduced extension moment, indicating that individuals are utilizing a movement strategy that doesn't require as much from the knee flexion muscles. Early stance, you can see a reduced moment such that knees with OA move in a way that requires less counteraction from the extensor muscles. And if you can remember from the previous graph, we already saw that there's less knee flexion with OA at the same time point. So less flexion equals less demand on the extensor muscles. And at terminal stance, in the severe OA group, you see that there's a much lower moment, barely crossing over the axis, indicating that the group is employing a movement strategy that requires less demand from the flexion muscles. The knee is in extension at this point, and there didn't seem to be a difference between the groups here. So the change in moment may be due to reduced ground reaction force. And a common way to reduce ground reaction force is to slow down your walking speed. And this is exactly what the severe group did. They walked about 30% slower than the asymptomatic group. So overall, we see that knee OA is associated with reduced joint moments, and particularly for those with severe OA, the knee moves almost entirely throughout stance, placing greater demands on the extensor muscles compared to normal knees. Another variable commonly associated with knee OA is knee adduction moment. A study by Miyazaki and colleagues attempted to determine this relationship between knee adduction moment and OA progression risk in a 6-year follow-up study. They recorded knee pain, collected knee joint adduction moment, using 3D motion analysis, and they took radiographs to evaluate severity. And the main takeaway from this study is right here in this table. Basically, they wanted to see which variables actually had a relationship with OA progression and how strong that relationship was. So throwing in several variables that are known to be related to OA, they found that age was significantly related, such that for every 1-year increase in age, risk of OA progression increased 1.2 times. But the strongest relationship occurred with adduction moment, such that every 1% increase results in an increase of progression risk of more than 6 times. So they found that baseline knee adduction moment, which indicates joint load, predicts radiographic knee OA progression. So if we understand that race and ethnicity are systemic factors for risk factors for OA, and we understand biomechanical abnormalities can be a local risk factor for OA, is it possible that racial differences may play a role in biomechanical associations with OA? So the answer is, yep, it's possible. Unfortunately, there's not much literature about this, but I was able to find 2 studies examining racial differences in biomechanical outcomes. Both studies compared African Americans and Caucasians. In a fairly recent study of elderly people in the Bronx, researchers found that African Americans had a slower walking speed compared to Caucasians. And although there were no differences in pain, African Americans were also younger, less educated, more likely to be female, and more likely to have diabetes. After adjusting for multiple covariates, differences in walking speed remained. However, this study population was not limited to those with OA. However, there was another study out of Duke University that was quite interesting and happens to be the only study that I'm aware of to examine racial differences in biomechanics in an OA population. So in this study, they had 175 participants of people who have symptomatic knee OA, and they engaged in walking motion analysis testing. So between race analysis showed that African Americans were significantly younger, had slightly higher BMI, and had a smaller proportion of people who attended college compared to Caucasians, but there were no differences in radiographic disease severity. Participants were asked to walk at a normal self-selected speed and a fast self-selected speed. So at normal speed, there were no significant differences in walking speed between the groups. However, African Americans had less range of motion at the knee, had slower limb loading speeds, and took a longer amount of time to reach peak vertical ground reaction force compared to Caucasians. But when walking at a faster speed, those differences went away. But interestingly, African Americans selected a slower fast walking speed compared to Caucasians. So that was the between race analysis. Within race analysis basically showed that different factors influence African American gait mechanics differently than Caucasian gait mechanics. So this study was able to show overall that gait variables do in fact differ by race in a knee OA population. Despite not having any significant differences in disease severity, African Americans had smaller knee range of motion when walking at normal speeds and self-selected slower walking speeds when asked to walk quickly compared to Caucasians. Although they didn't report specific numbers, the authors said that African Americans reported more pain, worse self-reported function, worse self-reported stiffness, and lower physical function self-efficacy. So their confidence in their ability to perform a physical task. So there could be something about perceptions of disability that could be affecting joint movement strategies. Clearly, this study shows that the potential for more work to be done in that there's potential for more work to be done in examining racial differences in biomechanics. So in conclusion, racial differences are apparent in prevalence, anthropometrics, and functional variables in OA population. And biomechanics do change in the presence of OA as well as with OA severity. And there's some evidence that biomechanics may differ by race in the OA population, but there's more work to be done. And this is important because it's possible that we may be overlooking vulnerable populations susceptible to movement patterns that encourage OA development and progression. And if there's differences in movement strategies, we need to know what are the differences driving, what are the factors driving these differences. This information could help improve interventions designed to treat and prevent OA development. It may beg the question, are there certain interventions that work better for certain groups and not for others? And how can we better specialize treatment for the individual? And so this is just a list of my references here. And if you'd like to contact us further, this is my information as well as my mentor's information, Ivanka Whiteley, here at the Thurston Arthritis Research Center at UNC Chapel Hill. And thank you so much for your time and attention.
Thank you, Dr. Flowers. That was a really fantastic presentation. And we'll now transition into the question and answer portion. So if you have any questions, feel free to type them in the bottom, and I will read them out loud.
Hey, this is Kirsten. This is from the OA Action Alliance, and I see we've got some folks typing in there. I just had a comment that I wanted to make because I think it's so key, Dr. Flowers, when you said at the end about vulnerable populations we may be overlooking and what can be done to encourage some of these populations to move, and how there's a great organization that you very subtly referred to when you put up that infographic on the vicious cycle of OA about the middle
That's
of your
right.
talk. Yeah, that was from Movement is Life, and I know you're familiar with them. They're doing, I think, a great service on the public health front with some programs that are going on in terms of
Absolutely.
getting some African American and Hispanic populations primarily to be physically active and trying to reduce those disparities and pay attention to those vulnerable populations. So I would just encourage everyone to check out Movement is Life whenever you have a chance.
Absolutely, yeah, and that's kind of the crux of what I wanted to say is that, of course, movement is important, and we need to definitely seek out those more vulnerable populations, encourage the movement, but we also need to be concerned about the quality of their movement, make sure that we are training or retraining people to move in a way that helps to improve their health. So not just moving, but how are you moving, and how is that going to benefit you down the line?
We have a question. So, has evidence supported an altered gait pattern of toe-foot biomechanics along with the altered knee patterns, i.e. toe out?
I.e. toe out. Off the top of my head, I'm not sure. I think there's been studies that have looked at toe out strategies to reduce ground reaction force or to alter ground reaction forces. So it's possible that other joints are affected, joint kinematics are affected using that toe out strategy. I'm not 100% sure, but I would imagine that utilizing a different foot strategy may impact the other lower limb joints.
Mm-hmm. Great, and let us know if that answered your question in the chat box. Another question has come in. How would you approach doing a study where you have equal representation from all races to be able to compare across race? Typically, longitudinal OA studies have had participation dominated by a single race because of the location where the study was conducted.
Yeah. So yeah, I can see that as being a problem, and that's something that I'm actually starting to learn. So I'm a biomechanist by training, but I just started my postdoc here at the Thurston Arthritis Research Center, and I'm getting more involved in epidemiological research. So one of the big studies that they have going on here is the Johnson County osteoarthritis study. It's been going on for over 20 years, and they're looking at racial differences between African Americans and Caucasians, and as well as Hispanic populations. And so I know that that's something that they've been working hard at, making sure that African Americans and Hispanic populations are represented. And so yeah, there's certain techniques that they utilize to overrepresent those populations to try to make sure that they have enough numbers there to compare. And I'm sure an epidemiologist would probably know how to answer this question a bit better, but that's what I have gleaned in my time here.
Okay, great. Seems very helpful, and hopefully that is the person who asked the question. Okay, it was. All right, and another question. Any treatment strategies, for example, should we focus on increasing knee flexion for the vulnerable populations?
Yeah, that's a good question. I'm not sure if we can really answer that, because really the question that we have to ask is the step before that, and to just make sure, are we in fact seeing differences between races when it comes to biomechanics? Like I said, I only found one study that focused on the osteoarthritis population. So there definitely needs to be more research to that end to find out what are the movement strategies that are being utilized within certain populations in OA groups, and then how do we develop treatment strategies to help improve that. So yeah, so it's a little hard to answer that question. We still need to build up to that.
Mm-hmm. Okay. Great, thanks. Yeah, we know that osteoarthritis disproportionately affects, different populations, so there's a lot of great research to be done here in this area. We've reached our time at 12:30, so I just want to thank you for presenting today, Dr. Flowers, and thank you everyone for listening. Our chat next month will be on June 21st with Dr. Cynthia Labella. She's an associate professor at Northwestern University who will discuss lower limb injury prevention.